This is EHJ Today at the Annual Congress of the European Society of Cardiology in London 2015. And I'm talking to Dipak Kotecha from the University of Birmingham, where he's a senior fellow scientist, and to Prof Collins, who is a professor of medicine at the Imperial College in London. Welcome, gentlemen.
Thank you. Thank you.
So we're going to talk about beta blockers in heart failure. And Dipak, you made an analysis, and why did you start this? Beta blockers is a very old story, so what's new?
It is an old story, and obviously it's one of our major guideline recommended therapies. But if you look at repeated observational studies, the Euro Heart Failure surveys, for example, we're not optimizing the treatments, and there are patients who should be getting them who aren't, and vice versa. And we set up the project nearly 10 years ago now. We wanted to get the individual patient data from all of the beta blocker trials that had run beta blockers versus placebo, the randomized trials. And that process takes a long time, individual patient data. So we were fortunate we got the groups of the leading scientists with Philip Poole Wilson while he was alive as well, to give us their original data. And we spent about 10 years of that time really harmonizing the data between each of the trials. So the baseline characteristics, the outcomes, etc., were the same in each of the trials. And that gave us a huge database where we could look at patients, for example, subgroups where they weren't originally well represented in the randomized trials. So this particular analysis looking at age and gender was really one of the main reasons we set up the group that many years ago. And it includes leading investigators from the US, around Europe, in Australia, as well as the pharmaceutical companies that have given us their data, the original data sets from those trials so many years ago.
So for our viewers, it's important to stress that you got actually the individual data, so it's not a meta-analysis like we read it every day in many journals. So it's actually looking at the individual data, so it's like a trial put together in one.
Yeah, you can think of it like a mega trial in effect. And so we had nearly 19,000 patients from 11 trials, and those actually represented over 95% of every patient that's ever been in a randomized trial between beta blockers and placebo. So you can assume that the results that you get are applicable to the patients that were recruited in the trials.
So what were the characteristics of the patients, and how heterogeneous were the data?
So they were heterogeneous, but actually in a way that's a good thing, because it tends to reflect the clinical population. As we know, clinical trials don't tend to recruit patients we see in clinical practice. Right. So these patients are often younger, they're very less often women, and so in particular this analysis and this size of this analysis gives us the opportunity to look at treatment efficacy in older patients, and in particular in older women who are very underrepresented in clinical trials. And that, although that was the case 10 years ago in clinical trials, it's still the case now. So if we look at the current trials that are ongoing, we still see very few women being recruited. Yes. So this type of analysis is really the only way you get sufficient numbers of patients to prove or disprove treatment efficacy in those patients groups.
So what were your main results?
So our main results, again looking at the entire population, we looked in particular at those in sinus rhythm. The reason for that was last year we presented at the ESC in a hotline, as well as a simultaneous Lancet paper, that beta blockers don't seem to have the same prognostic benefit in atrial fibrillation patients. And that was an important analysis. So now really we're looking at those in sinus rhythm. Right. And what we did is we looked across all of the patients in sinus rhythm who had reduced ejection fraction, and we found that there was no interaction for age. So if you were 50, your absolute risk reduction was about 4% in terms of mortality. If you were 75, your absolute risk reduction was still 4%.
But the absolute risk, of course, was higher.
Absolute risk is obviously high, but the reduction in risk is the same. And actually the number needed to treat was anywhere between 20 and 25.
In all groups?
In all groups. Yeah. So that suggests really that regardless of age, we should be giving patients beta blockers, if they have reduced ejection fraction and they're in sinus rhythm. Right. And then the other side of the coin was the gender aspect. And again, women had lower mortality, but had exactly the same risk reduction as men did.
How much was it in numbers, roughly?
In numbers of deaths, we had about 2,000 deaths out of about 14,000 patients.
And in male participants and female participants, what was the difference in event rate?
So the event rates were quite different in men and women. I think they were about 5 or 10% different over the, I think the mean was about 1.3 years in the trials. So there was a difference, but the women had exactly the same absolute risk reduction as the men did. And if you look at the secondary outcome, which was heart failure hospitalization, there was a slight attenuation of the results as people got older. You might expect that. But even in the oldest age quartile, those with a median age of 75, there was still a 3% absolute risk reduction, which equates to still a very, very good number needed to treat for mortality. And for women, they had exactly the same superimposable Kaplan-Meier curves as men did for heart failure hospitalization. So some really interesting data that really reinforces the fact that all of these patients, regardless of age or gender, should be getting beta blockers. And we actually went a bit further on. We looked at tolerability of therapy, because one of the key things I think that clinicians tend to think of is that older patients, and so by definition older women, are less likely to tolerate beta blockers. And in fact, the numbers of discontinuations were the same in placebo as they were in beta blockers.
That's interesting, yeah.
And they also achieved the same percentage of dose. So we looked at the maximal dose achieved, and it was 73% in women, 73% in men. And that was fairly similar across different age groups.
What about different molecules? You know, speaking about Paul Wilson, I mean, he published a COMET trial where there was a suggestion that maybe carvedilol would be superior compared to metoprolol.
Yeah, that's I do get asked that question quite frequently. When we set up the group, we were very clear that we were taking the totality of information. Certain people do think that there are differences in the different drugs. My own feeling is they're probably in the same spectrum of therapeutic effect. But I take that point. Obviously, there were different doses in the different trials as well. So we've tried to adjust for that, those factors. But I think the key aim of our analysis was to look at the totality of information. And for that, we need all of those patients that are being recruited in all of those trials. Because, you know, as you say, that group of women, particularly elderly women, is very, very underrepresented. And in order to get information on those, you do have to pool the data.
Sure. Now let's ask Professor Collins what he thinks about the study.
I think these are fascinating data, really. For the first time, we've got a real handle on whether more elderly women will respond in the same way to beta blockers, a very common therapy in heart failure population. The fascinating thing for me is that they responded almost in an identical way, and also the tolerability of the drug. I mean, we think that, you know, women are in some way, as they get older, the pharmacodynamics, the pharmacokinetics change. But actually, I think one of the major points that have come out of Dipak's study is that the dose achieved in these more elderly women was identical, and the absolute risk reduction was the same, albeit that the risk is increased as both men and women age. So I think these are really important clinical messages that, you know, we should achieve. We should certainly use beta blockers in heart failure. With reduced systolic function in patients who are in sinus rhythm, and we can use them in more elderly females and expect the same risk reduction. So I think that's a really and tolerability. You know, we've always wondered whether we should go to a half dose and not quite achieve the target dose, but I think this study really confirms to us that we should not stick with a half dose, possibly have a few side effects. We really need to get to target, and then we can expect a similar risk reduction. I think are really important basic messages.
So that's a good punchline for our viewers. Thank you very much indeed for sharing it with us, and talk to you next time.
Thank you.
Thank you. Bye-bye.